20 PANCE Practice Questions of Fibrillation with Answers and Explanations Part 1. Hello, welcome to the Science Guide ASAP Learning. Today, we are going to be practicing 20 PANCE style questions. Be sure to watch Part 2. Hope this helps. Please support this new channel by liking this video and subscribing for more videos like this one. Question 1. A 65-year-old male with a history of hypertension and hyperlipidemia presents to the ED with palpitations and shortness of breath. His ECG reveals an irregular rhythm with narrow QRS complexes. Which of the following is the most appropriate initial management for this patient? A. Immediate cardioversion. B. Initiate anticoagulation therapy. C. Administer adenosine. D. Start amiodarone infusion. Answer. B. Initiate anticoagulation therapy. Explanation. The patient's presentation is consistent with atrial fibrillation, which increases the risk of thromboembolic events, such as stroke. Therefore, anticoagulation therapy should be initiated to reduce this risk. Immediate cardioversion is not recommended in patients with long-standing atrial fibrillation, as it carries a high risk of thromboembolic complications. Adenosine is used to treat supraventricular tachycardia, but is not effective in converting atrial fibrillation. Amiodarone infusion can be considered in patients with unstable atrial fibrillation, but anticoagulation therapy should still be initiated. Question 2. A 75-year-old female presents to the clinic with a history of atrial fibrillation and recent worsening shortness of breath. An echocardiogram reveals a left atrial diameter of 5.5 centimeters and an ejection fraction of 35%. Which of the following is the most appropriate next step in management? A. Start digoxin therapy. B. Initiate rate control therapy with a beta blocker. C. Begin anticoagulation therapy with warfarin. D. Refer for catheter ablation. Answer. B. Initiate rate control therapy with a beta blocker. Explanation. The patient has a history of atrial fibrillation and an echocardiogram suggestive of heart failure with reduced ejection fraction. The initial management for this patient would be to initiate rate control therapy with a beta blocker to prevent symptoms of atrial fibrillation. Digoxin is not the first-line therapy for rate control in atrial fibrillation. Anticoagulation therapy is indicated in patients with atrial fibrillation to prevent thromboembolic events but should not be the first step in management for this patient. Catheter ablation may be considered in patients with symptomatic atrial fibrillation despite medical therapy. Question 3. A 50-year-old male presents to the ED with chest pain and palpitations. His ECG reveals atrial fibrillation with rapid ventricular response. Laboratory studies reveal elevated troponin levels. Which of the following is the most appropriate next step in management? A. Initiate amiodarone infusion. B. Administer adenosine. C. Perform emergent cardioversion. D. Administer heparin. Answer. D. Administer heparin. Explanation. The patient's presentation is concerning for acute coronary syndrome with concomitant atrial fibrillation. Heparin should be administered to reduce the risk of thromboembolic complications. Amiodarone infusion is not the first-line therapy for this patient. Adenosine is not effective in converting atrial fibrillation, and cardioversion may be contraindicated in the setting of acute coronary syndrome. Question 4. A 75-year-old patient presents to the emergency room with a rapid, irregular heart rate. An electrocardiogram, ECG, shows an irregular rhythm consistent with atrial fibrillation. The patient is hemodynamically stable. What is the initial treatment of choice for this patient? A. Cardioversion. B. Rate control with beta blockers. C. Anticoagulation with warfarin. D. Electrical cardioversion. Answer. B. Rate control with beta blockers. In hemodynamically stable patients with atrial fibrillation, the initial treatment of choice is rate control with beta blockers, calcium channel blockers, or digoxin. Cardioversion is reserved for unstable patients or those with persistent symptoms despite adequate rate control. Question 5. A 68-year-old patient with a history of hypertension and atrial fibrillation presents with sudden onset chest pain and shortness of breath. The patient is found to have a large pulmonary embolism. Which of the following is the appropriate anticoagulant therapy for this patient? A. Warfarin. B. Heparin. C. Enoxaparin. D. Dabigatran. Answer. B. Heparin. In the setting of acute pulmonary embolism and atrial fibrillation, the appropriate initial anticoagulant therapy is unfractionated heparin or low molecular weight heparin. Warfarin or direct oral anticoagulants such as dabigatran are typically started after the acute phase is resolved. Question 6. A 56-year-old patient with a history of atrial fibrillation and heart failure presents with worsening shortness of breath and fatigue. An echocardiogram shows an ejection fraction of 30%. Which of the following medications is contraindicated in this patient? A. Digoxin. B. Amiodarone. C. Flecainide. D. Diltiazem. Answer. C. Flecainide. Flecainide is contraindicated in patients with heart failure or reduced ejection fraction. Digoxin is commonly used in patients with heart failure and atrial fibrillation, while amiodarone and diltiazem can be used in patients with heart failure and preserved ejection fraction. Question 7. A 62-year-old patient with a history of atrial fibrillation and a CHA2DS2 VASC score of 3 presents for routine follow-up. The patient is currently taking warfarin with a therapeutic international normalized ratio, INR, range of 2 to 3. Which of the following is the most appropriate management strategy for this patient? A. Continue warfarin therapy. B. Switch to direct oral anticoagulant, DOAC, therapy. C. Add low-dose aspirin to the warfarin regimen. D. Discontinue anticoagulation therapy. Answer, B. Switch to DOAC therapy. While warfarin remains an effective anticoagulant, DOACs such as dabigatran, rivaroxaban, and apixaban have emerged as first-line options due to their improved safety profile and ease of use. The patient's CHA2DS2 VASC score suggests a high risk of stroke, and anticoagulation therapy should be continued to reduce this risk. Adding aspirin or discontinuing anticoagulation therapy altogether would not be appropriate management strategies. Question 8. Which of the following is not a potential complication of atrial fibrillation, AFib? A. Stroke. B. Heart failure. C. Sudden cardiac arrest. D. Pulmonary embolism. Answer, C. Sudden cardiac arrest is not a direct complication of AFib. However, it can be an indirect complication if a person has a pre-existing heart condition that increases their risk of sudden cardiac arrest. Question 9. Which of the following medications is not commonly used for rhythm control in atrial fibrillation, AFib? A. Amiodarone. B. Diltiazem. C. Flecainide. D. Digoxin. Answer, D. Digoxin is not typically used for rhythm control in AFib. Instead, it is commonly used for rate control. Question 10. In which of the following situations is cardioversion typically recommended for atrial fibrillation, AFib? A. A patient with chronic AFib and stable symptoms. B. A patient with acute onset AFib and unstable symptoms. C. A patient with paroxysmal AFib and minimal symptoms. D. A patient with persistent AFib and well-controlled heart rate. Answer, B. Cardioversion is typically recommended for acute onset AFib with unstable symptoms, such as hypotension or signs of shock. Chronic AFib with stable symptoms can often be managed with medication, while paroxysmal AFib with minimal symptoms may not require any specific treatment. Persistent AFib with well-controlled heart rate may also be managed with medication. Please like this video, subscribe for more videos like this and comment for more suggestions. Thank you for watching.